All right. So how do we assess, right? Our medical assessment tools. All right. What's the indication? Why am I giving this drug? Okay. You want to stop, look at your med list, say this patient is on 15 meds. Okay. What is the indication? Why are they on, Miralax, Senna, Colace, Metamucil? I could hear some of you laughing because I'm right. I'm talking the truth, right? They're on Plavix, aspirin, Coumadin, Aleve, because we're not speaking to one another, okay? Clinicians, make it a safe space when your nurse colleagues are asking you, hey, doc, why did you give this, right? That's something I've learned personally. It's not a criticism. It's a learning space. It's a learning point. It's an opportunity to say, Nurse Jennifer, thank you. Thanks for bringing that point up. My initial thought process was that I was going to order this, and this for their knee pain, neck pain, and then this to prevent a GI bleed. But maybe if I just do this, 1 to 3 times per week instead of 3 times daily, it will mitigate all of this other thing, right? So creating a safe space where we are not so inflated in our own credentials that we don't speak to one another and realize that there is benefit, and that trickles right on down, right? It is a way to communicate the nurse to provider, the clinician to the PT, the therapist with the social work team, so that that chart is a conversation. It is not an independent record that I 3-hole punch and keep it moving, right? So really sitting back to say, all right, what's the indication for my drug? What's my end goal? What do I hope to accomplish? How do I want to get this person better? Is my dosing correct? Remember, name dosing frequency. We noticed a change over the years, right, from our pharmacist colleagues and our EMRs to get away from writing QD, right? So we write out what we're saying. We're doing better in our, I'm still old school scripts, but in my EMR as well, spelling out exactly what I'd like to desire. And you know what? I don't know. If I don't know, we call the pharmacist and we discuss. So really knowing that we don't know everything and taking a step back to go through this list. Is there drug to drug? Is there drug to disease? Am I duplicating? Okay. Duplicating, number 8 is huge. Okay. Is the duration of therapy acceptable? I think that's another point of reference as far as a culture shift in our environments, is looking at, these patients that we're treating in our facility for years. Oh, they've been on it for so long, why rock the boat, right? But really looking at if we can taper dosing, if we can monitor to see response. Maybe they will become a little bit more socially engaged and less somnolent, more active, more interested, et cetera, more compliant, less agitated. So looking at our med list and cost effectiveness, as you know, is a big to do, both in all environments.